What if one day you just bend over a little and suddenly the pain is so bad you can't move? Don't just think it's a pulled muscle. The truth might be that part of your spine has collapsed inside. But don't worry, modern orthopedics has a minimally invasive bone cement technique. No big incision, just 3 precision tools to prop up the collapsed vertebra. That's called vertebroplasty. Vertebroplasty is done under local anesthesia. A thin needle is passed through the skin into the damaged vertebra. Then a special material called bone cement, the main ingredient is PMMA, is injected. After it's mixed into a paste, it fully hardens in about 10 to 15 minutes, but it can be injected during the stringy stage around 2 to 3 minutes after mixing. Once hardened, it supports the collapsed vertebra from the inside and stabilizes the fracture. The puncture hole is only about 3 millimeters. No stitches, very little bleeding. At the start of the procedure, the doctor mixes the bone cement powder with the special liquid in the right proportion and stirs it quickly into a smooth paste. Then the cement is loaded into a continuous irrigation injector, a special device that delivers a constant, low-pressure, low-flow output. The outlet of the injector is tightly connected through a sterile tube to the back end of the working channel that has already been placed into the damaged vertebra. The doctor slowly turns the plunger, so the bone cement is pushed out of the tube under steady, low pressure, and goes through the working channel into the vertebra. The whole injection is done under live X-ray guidance, so the doctor can clearly see how the cement spreads inside. When the bone cement reaches the right stringy stage, not too runny, not too stiff, the doctor loads it into a filler. The filler is a long, thin tube with a screw-driven plunger, or a piston. Its tip can reach deep into the fractured area. The doctor slowly, under low pressure, and in a controlled amount, pushes the cement into the cavity that was mapped out beforehand. The technique is called fill while withdrawing. As the doctor slowly pulls back the tip of the filler, the cement is continuously injected. This spreads the cement evenly inside the vertebra, instead of forming one big clump. The speed of withdrawal has to match the speed of injection to keep the cement from leaking backward toward the spinal canal. The pressure is kept very low and the injection is very slow while the doctor watches the cement spread on the live X-ray. If there's any sign that the cement is starting to leak toward the back of the vertebra, the injection is stopped immediately. For patients with a severe burst fracture, or a fracture that has already caused a hunchback deformity, what we call kyphosis, using bone cement alone may not be enough to restore the height of the vertebra and keep it stable. In those cases, we combine the cement with pedicle screws. Metal screws are inserted through the pedicles into the fractured vertebra and the healthy ones above and below, then connected with titanium rods. This metal construct acts like a steel rebar frame inside a building. It corrects the deformity and shares the load. In practice, the bone cement is often injected first to fill the internal cracks, and then the pedicle screws are placed to provide external fixation. This gives you internal filling plus external fixation, a double layer of stability. Vertebroplasty is mainly used for painful osteoporotic vertebral compression fractures in the acute or subacute phase, as well as for vertebral hemangiomas, multiple myeloma, and pathological fractures caused by metastatic tumors in the spine.